The topic of this talk will be stability in posterior wall acetabular fractures. I'd like to thank especially two of my co-authors, Clay Spittler and Calvin Schlepp, for doing the lion's share of work in regards to gathering the data. So posterior wall acetabular fractures are common injuries that account for about 20 to 30% of all acetabular fractures. Non-operative management is indicated when the hip is stable, and the hip tends to be stable when the native anatomy and the remaining wall can keep the head within the socket. Routinely, we use wall fragment size to determine stability. There's a number of different ways to measure the wall size, and recently it's been published that experts in the field of acetabular surgery cannot predict stability. And we used to think that wall sizes less than 20% were stable, and more data is suggesting that wall sizes less than 20% can be unstable. And this is most likely due to the complex hip anatomy and the many factors associated with it. So the purpose of our study was to see if there's any other fracture or anatomical characteristics that could help in assisting in determining stability. We want to look at the percent femoral head coverage. We want to look at the location of the fracture, specifically its relationship to the acetabular dome. We want to look at version, we want to look at center edge angle, and then we want to look at history of dislocation. This was a retrospective study looking at 11 and a half years worth of data. We identified patients who had isolated posterior wall acetabular fractures, and these patients had to undergo an EUA. They were categorized as either stable or unstable based on the EUA. Radiographs as well as CT scans were utilized to calculate roof and equatorial edge angles as described by Werner. We looked at lateral center edge angles. We looked at axial CT cuts to determine the location of the fracture in vicinity to the acetabular dome. And we also looked at the three previously described techniques for wall size. In regards to the percent femoral head coverage, we looked at the axial CT scans, identified the cut which had the largest diameter for the femoral head, drew a line from the anterior wall to the tip of the posterior wall at the fracture site, then drew a perpendicular medially and laterally and used this ratio to calculate percent femoral head coverage. There was overall 504 patients with posterior wall acetabular fractures during this time period, 138 of which underwent an EUA, 22 were unstable, and 116 were stable, and motor vehicle collisions accounted for the most common injury mechanism in both groups. When we looked at history of dislocation and percent femoral head coverage, there really was no statistically significant difference between the stable and unstable groups. When we looked at roof edge and equatorial edge angles, there was also no statistically significant difference between the groups, but as you can see, the ranges are quite wide for both unstable and stable posterior walls, and the same goes for center edge angles. What was statistically significant was the location of the fracture. In the unstable group, the mean distance from the exit point of the fracture cranially to the dome was about 5 millimeters, and in the stable group, it was about 9.5 millimeters. Furthermore, when you look at the table on the left side, you can see about 14% of the patients in the stable group that had fractures entered the dome region, and in the unstable group, 41% of the fractures entered the dome region, and 68% of the fractures in the unstable group were within 5 millimeters of the dome. And acetabular fractures that extended into the dome were at a significantly increased risk of hip instability. Now, looking at wall side, the Mowat and Keith techniques displayed statistical significance. Interestingly, when you look at the ranges in the unstable group, there were some fractures that was less than 20% wall size that were unstable. So we looked at the Mowat technique, and at 5 out of our 22 unstable posterior walls, that's 23% had wall sizes less than 20%. Looking at these patients specifically, 4 out of 5, so 80%, had cranial exit points within 5 millimeters of the dome, and 4 out of 5 had a history of dislocation. So there's a number of limitations to this study. It's got all the inherent limitations of a retrospective study. The sample size was relatively small in the unstable group. We couldn't account for the pelvic tilt calculations in regards to version calculations, and there's some data suggests that pelvic tilt does matter when you're making the version calculations. And then there's always the issues with human measurement error. So how do we decipher all this? I think stability has a number of different variables. When you look at wall size, I think the previous range where we discussed 20 to 50% being indeterminate has to really be increased 2, anybody who's got a wall less than 50% is indeterminate, and you should perform an EUA. In regards to cranial exit point or location, I think the more cranial the fracture is, and if it exits out of the dome, then it's more likely to be unstable. Soft tissue injury, specifically looking at dislocations. While our study showed overall that dislocation doesn't help predict stability, if you look at the small wall sizes, the ones that are less than 20%, there are a large number of these patients that dislocated. So maybe soft tissues, labrum, as well as a history of dislocation can affect your ability to predict these in small wall sizes. And lastly, osteology. In regards to the version values we got, there was a huge range, and I think studies that we're in the process of designing a prospective study with multiple centers to really decipher, does version matter, and also take a look at these other variables. And in the end, hopefully we can find a better way to predict stability in posterior wall acetabular fractures. Thank you.